Good morning. My name is Ada Skiles, and I'm the Associate Director of Chapin Hall at the University of Chicago. On behalf of Chapin Hall, I would like to welcome you to our first Child and Family Policy Forum. We would like to thank those of you who are here in person and those joining us in our live video webcast. I want to thank you for taking the time to be with us today. Today's program is entitled Public Systems Responding to Students Affected by Trauma. I'm sure you'll find the conversation both lively and informative. Moderating our panel of experts on this topic is the Chapin Hall Executive Director, Matt Stagner. Again, thank you very much for participating with us today. I'll now turn the program over to Matt, who will introduce our panel to you. Thank you.
Thanks, Ada. And I want to welcome everyone as well, especially those of you who are joining us live. We have about 100 people here at the Gleacher Center in Chicago, as well as several hundred folks who have signed up to join us on the web. We have a really, I think, timely and important topic to cover today, the issue of trauma and its effect on vulnerable youth and their involvement in multiple systems. For several decades now, Chapin Hall has been concerned with how children and youth interact with multiple systems over time or at any one time. The recent emphasis on the trauma that those youth have experienced, either before they come into those systems or while they're in those systems, has really raised lots of interesting questions, and we have three people who can approach this from unique but I think overlapping perspectives, and hopefully we'll have several minutes at the end for questions both coming in from the web as well as from the live audience. So let me briefly introduce everyone and get us started. Our first speaker will be Jean Griffin. Jean is both a lawyer and a psychologist and is an assistant professor at the Northwestern University School of Medicine. We also have Cheryl Smithgall, who is a research fellow at Chapin Hall. And we're especially pleased to have Margaret Porter, who is from out of town, came in from Rochester, New York. She is a program administrator for youth and justice programs and serves vulnerable youth in Rochester. So again, some unique perspectives. We'll let each of them speak for a few minutes, exchange some questions among the panel, and then open it up. Their full biographies are available to you in the packets that you have, so you can read about all the wonderful things that they have done. I also want to remind those watching online how to send in questions. You can do that either using our Twitter hashtag #ChapinForum or by posting questions at the UChicago Live Facebook page. So we'll see how I handle that, but it's all right here in front of me. Very good. So we'll begin with Jean, and I'll turn it over to him at this time.
Thank you to Matt and to Chapin Hall for inviting me to speak this morning. In starting the discussion about child trauma, what I want to do is define the term, because there is not a single agreed upon definition that's out there in the world, and so I think it's important for us to understand, or at least define, how we're using the terms. In your folders today, you have a white paper from the Illinois Childhood Trauma Coalition that goes into much more detail on the things I'm going to say, so you can work from there. The first slide is a classic psychology perception experiment called the figure vase ground illusion. I assume everybody can see the white vase. Yes, anybody who can't? Everybody can see the two profiles. I use this picture whenever I start talking about child trauma because that is one picture, yet it can be interpreted different ways. You choose how you're going to interpret that picture by whether you're focusing your eyes on the foreground or background. You can't see both images at the same time. You have to shift your focus. And that's what I'm talking about with child trauma. We will agree that a child we're talking about has a lot of issues, but there are multiple ways we can interpret what the child is doing, one of those being trauma, but there are other alternatives. So if I say to you, I have a child who's not sitting still, not paying attention, being disrespectful, overreacting, getting in a lot of fights, we could all agree that that's the behavior we see. And you will see that sort of behavior in every public sector child-serving system. You could focus on the being disrespectful, getting in a lot of fights, and you could say, this is a troublemaker who needs some limit sets, zero tolerance, call the cops, juvenile justice system, and send them off to be disciplined and have those limits set. Same kid, you could focus on the not sitting still, not paying attention, and saying, this is a kid who really may have attention deficit issues, refer for mental health referral and possibly medication, Ritalin, something to start addressing the fact that this kid is hyper and not sitting still and not able to stay focused and overreacting. You could also focus instead on the overreacting, hyper-aroused, and if you know about the kid's history, you might start thinking about trauma and saying this is a kid who's reacting as being triggered based on what this child has already experienced, and therefore start with the child trauma approach, which I would argue is focused much more on safety, support, self-regulation, building strengths to help the kids cope. So what I've done is given you three very different paths to start working with this kid. The, setting the limits, the start medicating and treating, the start helping work with the kid on the trauma issues. It's one kid, it's his behavior. It's the adults who are choosing how to interpret those behaviors. You're the ones deciding where to place the focus. And we make very different policy decisions based on where we put that focus. So it's one kid, one picture, we're choosing which way to interpret it. And so what I would argue is every child-serving system has traumatized kids in it, and they're some of the most difficult kids to work with. Now note, I am not saying that every kid in every system is traumatized, but I'm saying there's some trauma in all the systems that I've worked with. And so that's the next slide. Starting to try and define what I'm talking about, a classic NIMH definition is trauma is the experience of an event by a person that's emotionally painful or distressful, which often results in lasting mental and physical effects. So breaking that down, I would say there's three things that have to be present before I would say you've got child trauma. First, there has to be the event, and everybody pretty much agrees on that. Oftentimes, the press will stop there and say, that was a traumatic event. Well, actually, maybe. It's potentially traumatic, but just going through an event isn't sufficient to make something traumatizing. You have to then experience it in a painful way, and we'll talk a little bit about what that means. And it has to have some long-lasting effect, or what I would argue is really a symptom that you'll see, or set of symptoms. So the good news is that most people can experience these events and not be overwhelmed, not develop long-term effects. So that's where we start talking about resilience and what are the protective factors that a lot of kids can go through some tough stuff and come out okay. It's also the notion that you can have effects from the event and the experience, but there's treatment for it. You can get better over time. So there's also recovery. So I think it's important to recognize not just that not everybody's traumatized, but we also have some good research showing that it's possible to help kids recover from it if it does happen. So breaking down the 3 E's, events can include lots of terrible things: abuse and neglect, being a victim, domestic community violence, accidents, illness, natural disaster, war, terrorism. I'm talking about child trauma, but certainly from Iraq and Afghanistan, you see a huge increase in the military talking about post-traumatic stress disorder, which is a major problem, but we could have a long discussion about that. The military sort of talk about it was a good kid who went off to war, left high school and all-American, came back and was never the same. That's based on the notion of a person had normal development, then as an adult something terrible happened, they were almost killed and they come back different. What we're saying with child trauma is these kids don't get the normal development in the first place. They get hit young with the community violence, with the poverty, with a lot of those other issues. And so it's slightly different than adult PTSD. What are the experiences? The notion that these events are life-threatening, overwhelming, varies between people, even within the same person, can vary over time. So, for example, a 3-year-old might chase a ball across the street and a car almost hits him, and the 3-year-old might not even notice it. But the mother seeing it happen might be overwhelmed by seeing it. So, same event, an observer might get more upset than the person involved. Similarly, a kid who's been abused might not really understand all of what that means as a young child, but when adolescence kicks in and you get some of the more developmental and identity issues, they can then start showing a lot more symptoms and manifesting struggles with re-understanding what they've been through and what's happened to them. So over time, a person can change their understanding of what they've gone through. Also talk about experiences. Sometimes it's a single event, sometimes it's chronic incidents. And you get a lot of different effects, classic ones including nightmares, flashbacks, the whole fight or flight, dissociation, which is a shutting down when somebody's overwhelmed, can't fight, can't flee. You'll get cutters, and just with my limited time, I can't go into all the details. We'll have lots of kids who try and hurt themselves. Historically, you used to say all those kids were suicidal. We know now some kids are suicidal, but there's some cutters who say they do it to try and feel better. And I would argue those are probably some of the trauma kids you want to start thinking about. Hyperarousal, the kids are always on edge. They misinterpret cues all the time. They see the world as a threatening place and respond as though they're being threatened. When you, the adult, don't see the world that way, you don't intend your actions that way, but they misinterpret and overreact all the time. So those are common effects you'll see. The classic diagnosis for trauma is post-traumatic stress disorder, but note, post-traumatic stress disorder is extremely limited from my point of view when we start talking about child trauma. So post-traumatic stress disorder requires the event, requires the experience, and then the person must show a series of symptoms, must be re-experiencing. You have to have a couple of avoidance symptoms and a couple of hyperarousal symptoms. And what I would argue is that that whole cluster is a lot more than requiring a single symptom, which is the way I'm defining trauma. So, for example, we do research at Northwestern with Illinois Department of Children and Family Services, and overall, when kids come in to DCFS and we assess them, about 25% of the kids show a trauma symptom. 99% have been exposed to abuse and neglect by the time they come into custody, by definition. We have 25% at initial assessment showing symptoms, but less than 5% qualifying for a full diagnosis of post-traumatic stress disorder, because that's a specific cluster. You have to have a bunch of things. Similarly, there's an age effect where if you just look at teenagers, they experience it much worse, and it's hard to diagnose in babies whether or not they have trauma. But we would say for 13 and up, we're seeing over 50% of the kids showing symptoms, with less than 10% qualifying for a full post-traumatic stress disorder diagnosis. So I would argue we need to be focusing on the 50%. We need to be focusing on the overall 25%, not on the 5 to 10% that will qualify for post-traumatic stress disorder. That's a very different argument, 50% versus 5 to 10%. The long-term impact, we know if we don't do anything, the ACEs study, the classic study on what happens to kids who go through these early experiences of abuse, neglect, living with substance abusers, parents in jail, mentally ill, domestic violence. Research is pretty clear. You are more likely to develop a mental illness, substance abuse problems, sexually transmitted diseases, impaired physical health, academic difficulties, early death. These kids die younger, and these are some of the kids who will say, I know I'm not going to live to be 25, not with what they're going through. Centers for Disease Control has lots of good information on the ACEs study, carrying it forward. There's explanation of how trauma works. What is it? What's the mechanism? And this is the new brain development stuff that's been so useful in the last decade on understanding normal development. Also helps to explain trauma with this notion that this overwhelming experience disrupts normal brain development. So some of it is the neglect that children fail to get exposed to the proper experiences at the proper time during critical periods. So they may not have the strength and resilience of some of the regular kids. And then if you overwhelm the child's alarm system, it stops functioning as well. So the kid, in effect, ends up, the alarm system is always about ready to go off, gets too easily triggered, doesn't shut down easily enough at appropriate times. You have the kid who's always waiting for a problem, always on edge, always going off where some other people wouldn't be bothered, and then has trouble calming themselves down. And we can talk about the brain mechanisms that are involved in that. What do you do about it besides training? We need to be screening kids for child trauma. There are a lot of tools that are out there now. The National Child Traumatic Stress Network has a wonderful website where you can look up screening and assessment instruments. I would argue you need to be asking not only about events, but specifically about trauma symptoms. There's a lot of overlap between classic mental health symptoms and trauma symptoms, and so this is where you get into a whole diagnostic issue that we're still trying to sort out, gets into some of the definitional problems. There are, we know, some good effective treatments. There's some evidence-based. There's some promising practices. Again, the National Child Traumatic Stress Network site can help list a lot of those, and this is true. There's some parent-child stuff for young kids, there's individual treatment, there's group treatment, work with older kids. There's a lot of things that are being tried out there. I always talk about it in terms of the 4 S's, as I mentioned before. Start with safety. If the traumatized kid's not feeling safe, they're going to start overreacting. The adult support is essential to connect with these kids. Then you work with them on the self-regulation. That's why I would say the evidence-based practice comes in. Once you've got them feeling safe and somebody they trust, then you can work with them on calming themselves down and helping build the strength for the resilience and the recovery. And I would argue that if you do this with the kids in all the public sector systems, we can show how working with trauma issues for these kids can help meet goals of the different child sector systems. So for example, child welfare, I would argue if you treat trauma appropriately, the system should see decreased placement disruptions and should see increased well-being measures of the children. If you want to talk from a juvenile justice system, you should see decreased recidivism if the kids aren't acting out as much. You should see increased staff safety in terms of working with these kids if you're not triggering and escalating the issues. With education, you should see a decrease in suspensions and expulsions if you start working with these difficult kids in a trauma-informed way. And if the kids can sit there calmly and come in the morning and sit down and listen and feel safe in the environment, you should also be able to see some increase in test scores from these kids. So again, all those are different child sector systems, goals of those systems, and I think working and recognizing and helping deal with the trauma issues for the children can help the kids in all those systems. And there's my time. Thank you.
Thank you so much. Our next speaker is Cheryl Smithgall from Chapin Hall.
So on one of Gene's slides, he had the box of trauma up there and said it's a common theme across public systems that at least some children have experienced some trauma or may be affected by trauma. And a couple years ago, a colleague and I sat down and looked across a number of studies that were done at Chapin Hall and saw another common theme, which was that many of these children involved with public systems were struggling in school. They were struggling with educational issues. Sometimes those struggles were stemming from their experiences before they were involved with the public systems, and sometimes their experiences in those public systems. We began using the term vulnerable children to look across those systems and children, and we define that here, children who experience crises or disruptions in their home lives, often accompanied by parental absence or inability to fully meet their needs at that time, including their educational needs. This vulnerability makes them likely to become involved with public service systems. At that time, the protective capacity of their parents is also diminished, and we know from the work that Gene referenced that the difference between experiencing trauma and being affected by trauma can be whether that child experiences a consistent, caring adult response. We don't have any one data system that will quantify how many vulnerable children we have out there or how many vulnerable children in one school district or system, but I think it's helpful to look at the data for one system and talk about how we define that issue and how it relates to the numbers. So the data that you see on this slide here are from the Chicago Public Schools, and the pie chart on the left represents the entire district and a breakdown of the number or percentage of children who have been involved with the child welfare system. Less than 1% of those children are in foster care at any particular point in time. But up to 6% of children in the district have experienced substantiated maltreatment. Maybe 2% have been in foster care at a prior point in time. So altogether, maybe 8% of students in the district have had some sort of involvement with the child welfare system over time. That's not the same picture across all schools, however. So the pie chart on the right is representative of one particular school within the district. And in that particular school, when you look at those different categories of involvement with the child welfare system, you see that as many as 20% of children in that school have had some sort of involvement with child welfare at some point in time. There are about 40 schools that look like this in the district. That's about 6% of schools in the district. Those schools are more likely than average to be low-performing schools, schools that are struggling in general as a school, as well as having a number of children in that school that are struggling. So the slide draws out two things. It shows that vulnerable children are not distributed equally across the schools. It also shows that the scope of the issue depends on how or at what time point we define the population that we're talking about. So if we're talking narrowly about children in foster care at a particular time, that picture is going to be different than if we're talking about all children who have had any involvement with the child welfare system. And we know that there are many other children who have had involvement with other public systems or who are experiencing some of the other events that Gene referenced in his presentation, such as community violence, homelessness, having a parent with a mental illness or a substance abuse issue. I think here in Illinois, both systems have been recognizing these issues more. The Illinois Department of Children and Family Services has been developing a trauma-informed practice model for several years now. In Chicago, the school district has several federally funded initiatives that are designed to increase the availability of programs addressing social and emotional learning, violence prevention, and mental health. So in the next couple slides, I want to draw on findings across those different studies and show both the school's perspective and the child welfare perspective for some of these vulnerable children and the struggles they're having in education. So I mentioned that the Illinois Department of Children and Family Services has been developing a trauma-informed practice model. One cornerstone of their approach is the integrated assessment program. That's a program where caseworkers, child welfare caseworkers, and licensed clinicians partner together to conduct a comprehensive assessment of the family at the beginning of a foster care placement case. So at the, within 45 days of when the child is placed in foster care, they do a comprehensive assessment. The assessment is designed to look at medical, social, developmental, mental health, and educational domains for both the child and the adults who figure prominently in their lives. And this all gets pulled together in a report within 45 days of placement. So these excerpts that you see up here on the slide were drawn from a study in which we randomly sampled those assessment reports and took a look specifically at the educational domain and what was written there. And you can see here that in these assessments, there are connections being made between the traumatic experiences that children may have had and their experiences in school. There are children who are fearful of being punished for infractions at school, children who are easily provoked by their peers. There are children who talk with the assessment team about worrying about their siblings or what's going on at home and that being distracting from their schoolwork. And I think one of the concerns is that this can set up a self-perpetuating dynamic for the child, depending on what the response is to that child. So if this connection is made, if this is drawn out in the assessment and there is an intervention put in place or a caring response, that may resolve the issue. If there's a response that is more punitive in nature or restrictive, that may perpetuate the dynamic and cause the child to have additional behaviors and progress down a path that requires a more intensive intervention. The first 2 points on this slide, again, show that connection. And here, in these assessments, the assessment team was looking at particular issues that the child had at school and explanations or what was going on for that child. So in the first one, the child had missed a lot of school, and they found at one point that the child had actually broken into the school looking for a place to sleep. And the school had responded by suspending the child for breaking and entering in the school. This is consistent with some past research that was done at Chapin Hall on children who run away from foster care, finding that although they might not have been engaged in the academics and in the learning, they were engaged with their school, and they saw the school as a place to go. There were children who were showing up at school, maybe not attending classes, maybe not engaging with the learning, but they still saw the school as a place to go. The second one, the girl being referenced was in a fight, a significant fight at school with peers, and in talking through what had happened, the girl was able to talk about how something that the other girls had said had provoked memories for her of the abuse that she had experienced before. The last point on this slide, I'm sort of flipping now to the school perspective, and this comes from work that colleagues of mine have done, Gretchen Cusick and Lisa Walker, with some school-based interventions and evaluations of those programs. And a school administrator is talking about a child that would come to school and in their words, abuse all the little girls. And they didn't know where it was coming from, and they thought, well, this is just a bad child. How do you know? How can you get that information out of a 5-year-old? So it shows that if in the absence of that context, the focus is on the behavior and the attribution is to the child. In those studies that I just referenced from the school's perspective, we have also been looking at the introduction of trauma-focused interventions in the schools and talking with school administrators about the range of interventions that they have. And one of the themes that came through is the prevalence of seeing the children as being angry about things. And I think this this ties into in the issue paper that you have, the white paper that you have in the folders that were distributed and that's accessible online, that Jean and Anne did. They talk about children misperceiving cues as threatening and having reactions that seem out of proportion to what's going on. And I think that's a good example in this first bullet of that happening. A child's pencil rolls off and they're screaming, they're volatile, somebody stole my pencil. And the administrator, the school staff, they feel the anger and they react to that situation, perceiving that child's anger. And that anger is more observable than the psychological trauma that may be underneath. The second quotation also ties into something that Jean had mentioned earlier, that there's this tendency to focus on the behaviors. And here you have a school administrator who's sort of recognizing that. She's saying, we get around the table and we talk about the behaviors. Is the behavior inappropriate? Yep. Is it unsafe? Yep. Is it irresponsible? Yep. And then they go on and address the behavior. And this person was asking for more depth to that, more understanding of what was behind the behaviors, and maybe that would offer different intervention options. A second theme at the bottom of the slide here was that schools struggle to engage the very difficult to reach families. They can work with the families when the families come to them, when the parents show up for parent-teacher meetings, things like that. But it's really difficult for them. They do not have that expertise necessarily to go and engage the family that is resistant to that involvement. Here they're talking about using out-of-school suspensions when they approach the parents and feel like the parent is not cooperative. And you see that they're balancing this tension of addressing the needs of an individual child and addressing the needs of the other children in the school as well. So there's a strong interest in working across systems. The Administration for Children and Families has awarded a number of grants designed to foster collaboration between child welfare agencies and schools. A number of public systems are increasingly recognizing the need to look at the educational experiences of the children that are involved with them. And schools are increasingly recognizing the range of non-academic issues that their students are dealing with. Understanding trauma and its impact on child development and learning provides a common framework for professionals that are working in both of these systems. But we still have gaps or overlap between these systems depending on how we define the issue. I'll continue to use child welfare as an example. It is by design intended to be temporary or short-term. We don't intend for the system to raise children throughout their entire childhood till adulthood. So if we're going to think about interventions that are occurring through the child welfare system, do we also need to think about how those interventions can stay with the child, or how we can continually support the child or family when their involvement or the nature of their involvement with the child welfare system may change over time? School professionals want someone to reach out to when they're searching for ways to help a child in foster care, but they also want someone to turn to for the child who experienced maltreatment and maybe their case is closed now, or the child whose family is homeless, or the child who's living with their grandparents while their parents are incarcerated. They deal with a lot of vulnerable children. Not all of those vulnerable children are involved with the public service system at a particular point in time. So to the extent that education policymakers are interested in improving underperforming schools, they need to be interested in the lives of vulnerable children. I think that's where these systems overlap. Those children are most likely to be, or more likely to be, in underperforming schools. To the extent that child welfare administrators are interested in educational outcomes of children in foster care, they need to understand the dynamics of the schools that these children are likely to be in. They also need to understand what innovations are there in instruction that might benefit those children. There are a lot of programs developing, evolving around online education, credit recovery, other things that might be particularly applicable to children in the child welfare system who may have disengaged from school. I want to take this down, this idea of cross-system collaboration, down to the field level for a moment. Child welfare professionals have an expertise in assessing and working with families in crisis. That's their domain. Educational professionals have an expertise in identifying and implementing instructional approaches that work for children with various needs and abilities. So they both have an expertise that they can bring to the table in this collaboration. We did a survey last year of about 1,500 child welfare caseworkers here in Illinois. Now, they've been experiencing trainings, participating in trainings on trauma and child welfare, and we asked them to look at a list of activities. Are these things that you have a responsibility for? They responded yes or no. And then, how important are these things to achieving good outcome? And I pulled out a couple things from that survey, a couple findings. About a third of the caseworkers who were surveyed reported that they felt that teachers and other personnel understand the impact of childhood trauma on children's functioning to a great extent or very great extent. So it seems like there is room to develop more of an understanding there. This was noticeably lower than the responses that caseworkers gave for, say, mental health professionals or others who might have more experience with trauma. And almost 3/4 of them said that raising awareness among teachers and school personnel about the potential impact of childhood trauma is very or extremely important to good outcomes. So they recognize that there could be a benefit from increasing that awareness on the education side. Yet, when I've been out in the field talking with staff in the field offices about this, I've heard from a number of caseworkers. They agree with this, they're not surprised by these findings, but then when they talk about it, they'll say, but I'm not sure it's my place to raise that awareness with that teacher. I'm not sure it's my place to go into the schools, and I don't know how to connect with them about this. There's an interest in doing it, there's a recognition of it, but they're not necessarily feeling like the door is open for them to take on that role. And I think it's worth saying we didn't survey teachers on the other side. There may be parallel issues on the education side where they're wanting to know more from child welfare professionals or others involved with the public service systems as well. And they're wanting increased recognition of some of the things that they feel like they need from the adults involved with these children in order to have good educational outcomes in their system. These are some of the recommendations that appear in some of the reports. The boxes that you've seen at the bottom of the slides reference the various studies that these excerpts were drawn from. And these are some of the recommendations that we had across those reports. Putting in place systematic front-end assessments like the integrated assessment program that the child welfare system here in Illinois has. We are evaluating that program and see a lot of potential in those assessments. I think the next step is to see what is done with those assessments, and to the extent that they are shared with a wide range. They're shared with the courts in some jurisdictions, not in others. They're shared with some school professionals. They're shared with providers who are working with the children, and what that does for good outcomes for the children in terms of providing context for what the children are experiencing and how that connects to their learning. Creating mechanisms for sharing information across systems. This is referring to, at the systems level, data exchanges, having each system be able to know which children are involved and who might connect for that specific child. It's also that information sharing that I referenced in that last slide about the survey, so that professionals on both sides feel like they can come to the table with their expertise and exchange their ideas about what might work to support that child and that family. Providing vulnerable children and their families with high-quality developmental and educational supports as early in their lives as possible, and maintaining the supports if disruption occurs in the lives. This, again, is recognizing that involvement in a public system may be time-limited. It may be designed to be time-limited. Yet when we take that trauma focus and a developmental lens, we see that there are risk factors for infants involved with public systems who may not be involved with that system at the time that they're involved in schools. How can we connect those ideas? Here in Illinois, there are policies in place to enroll preschool-age children in quality preschool programs and address the early childhood education. School mobility is an issue of interest in the child welfare field right now. And as we look at those issues and we look at the environment that can best support the educational needs of the child, we also need to be thinking about how that will be continued if another transition occurs, if that child goes home, is reunified with the parent, if the child moves to permanency. When we look at the issue of school mobility, all of those different categories of involvement with the child welfare system have somewhat increased mobility relative to children who have no involvement at all. Creating trauma-informed school systems. I think here we're talking about helping teachers learn how to recognize possible signs of trauma, coaching them on how to respond to students who may be acting out this distress in their classroom, and redefining the adult roles and responsibilities with respect to the overall school climate, using restorative principles and practices and non-punitive responses to address the child's needs. And then, of course, in all of these, we have some children who are involved with some of these systems who are not currently enrolled in a school. And so paying attention to how we can re-engage those, particularly those older youth. There are issues particular to adolescents in here. It may be even more difficult to separate out the trauma or recognize the anger as being reflective of trauma when we're working with adolescents. And we need to develop the expertise that we have or the connections that we have in terms of re-engaging those youth in their learning. And then all of this really requires that we align our policies and our funding so we can support these efforts. With that, I am going to turn it over to Margaret.
Thank you, Cheryl.
I'm going to try to move quickly because I have a lot to cover. I'm Margaret Porter, and I'm from Rochester, New York. And for those of you that may not be real familiar with the area, Rochester, New York is located in upstate New York. It's about 60 miles west of Syracuse, New York, and 60 or 70 miles east of Buffalo, New York. The population of the greater Rochester metropolitan area is about 1,100,000. Population of the city of Rochester, of which I work at the Rochester City School District, our student population, families that we service, there are approximately 210,000. So, Rochester's upstate. I want to go through this a little bit just to give you a little background so that you can see what I'm working with. 79.7% of our youth qualify for and or receive free and reduced lunches. That's by federal guidelines. 16.9% have learning disability or classified as special education. And our families, 63% are Black or African American, 22% are Hispanic, and a little over 10% are white. We're 27% English language learners, representing about 30 countries around the world in our district. Youth and Justice Programs is a component part of the Rochester City School District. We have right now in Youth and Justice, of which I'm the administrator, we have one program that's really a district-wide program and indirectly certainly affects education, as I'm going to explain to you. The others are either mandatory, where the court has sent the child to this facility, and our teachers have classrooms all over the city in these facilities, mental health, or their voluntary placements that function as alternative school settings. Incarcerated youth. I'm going to just run through this because I want to spend more time on the voluntary programs. We have 2 jails in Monroe County. Last year we had about 1,600 school-age student intakes. In the incarcerated youth program, not all of the 1,600 certainly are from our high schools. There are kids that are out of school in a GED track, trying to get that certification, and then certainly a number from our mainstream high schools. What's going on here? Secure detention. Secure detention in New York, if you committed a crime under the age of 16, you would go to secure detention, the Children's Detention Center. Again, our county partners. And I want to mention that everything that we do in Youth and Justice is a collaborative. And we're very lucky to work with the County of Monroe because truly we are collaborating. Secure detention, full day of school. I also want to mention that all of the Youth and Justice education programs have credit recovery involved. That means where a student is a grade or 2 grades below grade level or has not achieved adequate credits to really be on track to graduate with his class, we offer in facilities and in our schools credit recovery. I really want to mention that that means that if a student failed a course that was required for graduation or an elective course, they may do that course again online. And that's after school, free periods, and certainly with the incarcerated youth and the secure detention, we can use that very often, and we get a lot of kids to recover that credit. We also have full summer school. So the incarcerated youth program has a lot of aspects. We have vocational education, life skills training, chemical dependency, treatment and group, and we have a young men's group that all occur with the incarcerated youth, and secure detention. Non-secure detention, those are our PINS kids, persons in need of supervision. And that means that possibly a school district, or our school district, other school districts in the County of Monroe, filed a petition because of chronic truancy. The school had done everything they can to re-engage this child or engage him or her in school, and it's not happening. So they filed a petition with the family court. The other is ungovernable youth. And that pretty much means that mom and dad are saying, look, I need help. This child is really not abiding by any rules in my house. And oftentimes the ungovernable kids may also be truant. And in that situation, our teachers are working with youth. And in that non-secure population, we see many foster care youth going into the system of foster care out of non-secure detention. University of Rochester at Strong Memorial Hospital is a behavioral health component. We have youth in there, grades K through 12, who are in mental health crisis. So we have an elementary component of classrooms. We have an inpatient and an outpatient areas for adolescents. And what's really wonderful about this strong collaborative is our teachers are part of the treatment team. So that daily there's case conferencing, not only about the academic progress of the child, but also the non-academic, which is a huge focus for youth and justice programs, the non-academic piece. And what's happened there that's really exciting is that because the psychiatrists in the unit and the clinical social workers lead the team in treatment, our teachers are really using best practices for mental health, which certainly are best practices in a classroom setting. So for example, they would know what kind of wait time do you give a child before you attempt to refocus them back to their task. And learning a lot of de-escalation techniques throughout these programs. Now I want to get to the ones that I'm here to talk about. Fast Track, Rochester Educators and Probation Officers, and New Beginnings. Unity Health, so I'm going to really have to go fast. Fast Track Rochester. This is something that I want to tell you how this came about. This is a collaborative with the Monroe County Sheriff's Department. It exists in the Monroe County Correctional Facility. We have a number of female custodial moms and grandmothers that are incarcerated in the correctional facility. And one day a lady asked the deputy in her area if she could please talk to one of the school teachers of the young men and women that were incarcerated. And we talked to her, and she said, you know, I'm just really concerned. I'm not in the house, and my 18-year-old son isn't going to go to school. And I've got a daughter coming out of a juvenile justice facility, and she's going to come home, and she's not even going to register for school. She's not even probably going to go to school. And we thought about this and said, talked with our partners at the Sheriff's Department, and said, how can we collaborate on this and really service our own children? They are our children from the Rochester City School District for the most part. Well, we have a social worker assigned to that group, and pretty much now that they know that she's there to try to help them keep their family intact and not try to take their kids away because they're incarcerated, because that's the original thought of a lot of the moms and grandmothers, they're just thrilled to have her assistance. She visits the homes where the children are staying. She works with mom. She has the kids in groups in some schools where there are a number of youth, and does individual counseling. What are we finding, and why is this important? I really feel in some ways we are really a diversion for child protective custody, because mom's telling us the problem. The other thing, and we can certainly not, certainly we do engage child protective when needed, but in some ways we can refer and assist so that that is a diversion. What are we finding? We're finding youth that stay, possibly have moved from the east side of the city to the west side. And the people that the child is staying with didn't know that they could call transportation and alter the route for the bus pickup for the child. So because they don't have transportation for the child is staying home and they're truant. So we can fix that real quickly. We're finding kids that are moving from house to house to house. So according to McKinney-Vento, they are homeless. And we work with our county partners, and also they're entitled to everything in our district for homeless youth. So I want to move, but I could go on because I think that serves an important district objective in re-engaging and engaging. Rochester Educators and Probation Officers, real quickly, that's a program that we are lucky enough to have in the offices of probation downtown. They've given us a classroom to see how this goes, and we have young men who are assigned to adult probation in that classroom. Why are they there? Maybe the probation officer said, you might want to try this, you're not succeeding in your high school. Again, we're doing the credit recovery. Some of them have after-school jobs. Who are the kids? Primarily maybe gang members that are very entrenched. We've had sex offenders, and it's voluntary. And we do get a lot of kids coming and going from the jail, but they come right back to us. We don't cut anyone off. They can come back to our programs. We don't have anything like you have this amount of time to change and all your problems have to be solved. We don't do that. It's very individualized. Again, case conferencing. New Beginnings, that's exciting with our partners from the Center for Youth Services. That program is unique in that we've taken a lot of young men from jail that really were not succeeding in their high schools, and we put them in this program where there are so many additional services and supports. Center for Youth Services actually has housing, so they can do transitional housing for youth, they can do emergency housing, and they have housing for pregnant and parenting females. Additionally, they have counseling, men's group, activities at the center after school. They don't have to go home. And we do a lot of celebrating and recognizing kids. And we really make a real effort to establish an asset building model for each of these programs. We agree the deficit model doesn't work. Unity Health, that's a recovery program. Our teens from our high schools that are evaluated as chemically dependent, they can have a full day of school and they get treatment during the day. individual and group every day while we're not in school session, those students are still able to come to Unity Health. One of the things that's really interesting about Unity Health, and I value very much, is we have an advisory board. And it's great because a high level, actually a deputy director of Monroe County Probation takes her time and comes to that meeting bi-monthly. We have a city council person on our advisory board. We have 2 principals, elementary and secondary. We have treatment people, certainly our partners are there, and our own staff that works at Unity. So it's a really, really nice group, and we get a lot of support, referrals, et cetera, from that group. Water Tower Academy is very popular with our family court. We always have a waiting list for that program. It's our younger kids, 14 to 16, that are really not working out in their mainstream school, or they're not attending. Maybe they've been in several foster care placements, they're not working out. And what we really do there is have a full day of school, but our kids are in a lot of groups. They do a lot of field activity. For example, in the spring, every spring everybody gets a camera, and we do writing through photography. So you pick your theme. What we're interested in is the writing, obviously. And there are a number of field trips and celebrations, big Thanksgiving dinner coming up. So what are the things that we think are important in the Rochester City School District through the Youth and Justice Program? A strong staff of urban educators. What I mean by that is basically that people are familiar with urban life. They're familiar, or they're part of the culture, but they're urban educators, and they're people that want to be in the position they're in. They want to do that. And to be honest, our social workers are not in a building. They're not sitting there and having appointments. It doesn't work like that. They're in the field. We're doing some grassroots social work because we see that family connect, that involvement, helping families out to get them referred to appropriate facilities and working with our county partners is really important. I value the county's input and how we work with them because they have so much involvement with our children and their families through the county system. If you just look at probation, incarceration, financial assistance, foster care, just so many areas in the courts, et cetera, that they have a lot of information about our children and our valued partners. Thinking from a family perspective, when we go into a house and work with a student, mom might be interested in student X, but when we get there, there are multiple other children at times, and they also have other issues. So we really have to not only connect with our community-based organizations, collaborate with our county partners, but we've also got to reach into our schools and work with each child. Moving events and services into the city, one thing that we found a great success with, and we just love doing it, is we don't have our parent and student nights in a school building. We have them in the communities where the families live. So we partner up with a community organization that has services that the family may want or need: employment service, drug and alcohol, daycare, tutoring, and we move in that facility for that evening with our teachers and welcome parents and work together to service our families. And we think that's really important. We do that on the east side of town for those students, and also because the mobility and ability to get to school buildings sometimes with little children, taking the bus is very costly. So that seems to work out. Voluntary placement throughout our programs. We don't force anybody to come. We invite mom and the student. If mom can't make it, so the student can come. If mom says it's okay, we'll work something out where that child can come there and see, because we want them to want to come and feel comfortable about what's going on in their lives. Rolling enrollment throughout the year, safety focus. Our programs are located in neutral areas. For example, with the youth that we work with, sometimes a west side kid certainly won't go to the east side, as many of you know. So we try to find what we call a neutral area where kids feel safe. Also in the classroom, getting kids to feel safe to answer and respond. Building that trust in the classroom is huge for us. Seamless and individual instruction. Our kids move from facilities to detention, jails, whatever. We do our best to ensure seamless instruction. What does that mean? We do individualized instruction. In a social studies class in jail, in any of these facilities, you may see in that social studies class a student doing U.S. history, another student doing Global Studies 1, another student doing economics. Everyone has the work that corresponds to their own course selection sheet from their high school, and our teachers do preps with those youth. So that we're trying to keep them actually right on target moving back into their classroom. Youth exiting the program, once again, we don't ask people to leave. Basically, it's based on the case conference, parents' involvement, students' desire to return to a mainstream, and many students want to just stay with us. Minimize or non-usage of long-term suspensions. Yes, that hasn't worked, especially with a kid who's gone through a lot of separations, a kid who's been incarcerated, detained for some reason. Long-term suspension, that whole concept doesn't seem to do much to benefit the child. Now, there are programs that are wonderful in our long-term suspension building, but I think the overall concept means you're eliminated. And we don't want to do that because that's her history. So we don't really, I think I long-term one person last year because the Rochester Police Department came and got him, and he had 28 bags of crack cocaine. And so going through security, he had to be because it was intent to sell. But by and large, we don't use long-term. Participant return policy, not exclusionary. That means basically that if a kid goes to jail, if they go to secure detention, wherever they go, they can come back. If they're in repo, as long as they're on adult probation, or if they're in the water tower, that can be their home school if they want it to be. Collaborating with our county and our advisory board, and then program linkages to grants and contracts. We do a lot with grants and contracts, certainly to enhance the services we're able to provide our students. So I don't want to take any more time, and thank you so much.
Thank you, Margaret. We'll now turn to the panel for questions and discussion. I have one question that's come in via email, so I will begin with our web audience and would encourage anyone else out watching over the web to send in questions, and then we'll weave those in with the live audience. The question in from the web, and I'm going to turn to Jean first for this, is I'd be interested to hear more about how neglect can be experienced by trauma. There's a lot of information about how neglect results in attachment difficulties, but not about how it can be experienced as trauma. As many of you know, most children in the child welfare system are there because of neglect rather than physical or sexual abuse. So if Jean could reflect on that, and then if other panel members wanted to elaborate.
Sure. I think for some of that I would go back to talking about normal child development and normal brain development, and this notion of there are critical periods where children are supposed to learn certain functions, whether it's physical development, whether it's emotional development, such things like attachment, or whether it's cognitive development, language, and other tasks. If you are neglected and you're not learning not exposed to the right experiences at the proper time, so the neglect is a lack of experience. Chronic neglect can alter brain development. Your brain responds to what it's exposed to. So if you have kids who have failure to thrive and are less physically developed, if you have kids who don't have proper attachment and so they don't have healthy emotional development and they can't develop trusting relationships with adults, if you have kids who cognitively just don't get the exposure, don't learn the language, these are kids who are going to be much more vulnerable to later events. And so if we talk about resilience and protective factors, these kids won't have it. And so I think what happens is with neglect, the kids are much more vulnerable and already have some damage, if you will, from the failure to have appropriate healthy development, that moving them into a healthy environment can start to get them to recover, where they'll have better abilities to respond. They can learn more appropriate ways to react. They won't be having the tantrums. This would get into the kids who are, chronologically 15, but they look like they're 20, but they're acting like they're 10. And those problems are set early, and so that's where I would define some of that within child trauma by my definition.
Cheryl, from the integrated assessment issues, is there anything you want to add to that?
I would just add that although we know from the administrative data that a larger proportion of families are involved with the system because of neglect, the actual reasons behind that can be a little more complex. And so if there's domestic violence in the home, it may show up as neglect. There can be shaken baby syndrome that shows up as neglect, because the system, the child welfare system, has to focus on what the parent is or is not doing for that child. And so I think that goes back to Jean's point about protective capacity, that there may be other issues going on. And then we know that a lot of these families also live in areas that have high crime and violence, and some of the other factors that Jean listed, may be events that they experience, and again, that protective capacity may be diminished.
Great. Margaret, did you want to add
from
to
an
that?
education perspective, kids often become disinterested in school. There's no one at home to please by getting the good grades if they're neglected. And the choices sometimes that neglected kids make are not in their best interest.
Great. As the audience thinks of questions, I'll start off with one from myself, but I welcome, just raise your hand, and we have a couple of people with microphones who can come around and hand you the microphone. I was thinking, after Jean spoke, of really what a positive message there is here. It's hard to see it sometimes. But we have a framework for thinking about this problem. As Jean noted, we have some evidence-proven efforts. So I wondered if we could put more resources into this area, if we did put a toll on Lakeshore Drive and the mayor came to you and said, let's use that to address issues of child trauma in our system. Where would we begin? Is it still an awareness issue, as Cheryl suggested it may be? Is it an education issue for the professionals in the system? Is it a training system? In a way, we seem to know what to do here, but we need to organize ourselves to do it. So I wondered where you might advise the audience on a first step in that direction.
Actually, I'm going to ask Margaret to talk a little bit, because she and I have talked individually about the Rochester school system wanting to develop a trauma-informed approach across the schools. And so I think where they're at is one point where that investment could be made more.
We're looking at it first from an education point of view, from professional development. Our current superintendent, Dr. Vargas, is committed as one of his goals, in conversation with me personally, to invest in training the entire district staff to be trauma informed. And that's a beginning. We have a very active and substantial team that have expertise in grief and loss, and certainly turnkey that into the community very often. But I would say from a professional, from the perspective of professional development, that for us would be a starting point, the awareness, and then continued training.
And I think I'm in the middle for a good reason here, because I'm going to kick it back to Jean in a minute. But from the evaluation that we've done of the integrated assessment program, I think there's a lot of material there that draws out the connection between trauma and education, and trauma and learning. But then it begs the question of where do you go with that, and how does a system that has developed more capacity among the caseworkers and the assessment teams to recognize that, where do they take that? And I think Jean can probably speak to the provider side of that a little bit more.
Well, and if I were king, I'd actually sort of turn the whole thing around. I think we're actually focusing at the wrong end. I would start by having all these child-serving systems agree on what is normal, healthy development, which we don't do. Our system is all negative focused. And if we could agree on what's normal, healthy development, and we can do trajectories of what that should look like. For those of you, any of you who had kids, you take your kid to the pediatrician when he's 2 months old, and I have 3 boys, and the doctor could tell me how tall each of them was going to be when they were 18 years old and how much they were going to weigh and what's the 25th percentile to 75th percentile. You have these wonderful trajectories on physical development. We should have that for emotional development and intellectual development as well. And if our goal of all the child serving systems was to get these kids who deviate back into the normal range, that would actually be a common goal of all the systems to serve the kids. So rather than focusing on the negative end, I'd want to focus on the positive. And you can make all your systems trauma informed, institutional or community based, and obviously it should be both. Some of these kids are dangerous. We're not trying to deny that. Some of these kids need structure, they need help, but you don't do it in a punitive, yelling, zero tolerance way. So I think there are very specific ways we can get into, but I'd flip the whole system in terms of what we start looking for.
Great. We're getting some questions here. We'll begin in the back, and if you could state your name and affiliation, and then notify which panel member you might wish to answer if you have a particular one.
Yeah, my name is Lorraine Forte. I'm the editor of Panelists, Chicago. And I have a question for Cheryl. You talked about 40 schools where you saw a greater than average prevalence of kids in the foster care system. Can you talk a little bit about those schools and what you saw there and what kind of supports they might have been getting, to deal with the problem?
Sure. So that work that we did really looked at the systems level and linking the data between the child welfare system and the school district school system. And so the most that I can say is that there is this small percentage of schools that have an overrepresentation, not necessarily of children who are currently in foster care, but of children who have had some involvement with child welfare over time. So, there may be significant numbers of them who have had some sort of substantiated maltreatment in the past, but have not spent any time in foster care, or have spent some time in foster care as an infant or a young child and aren't currently in care, and then there are some that are in care. And I think the point I was trying to draw out there also is that there are a number of children who aren't involved with the child welfare system but are experiencing other issues that make them vulnerable or that put them in that category of vulnerable children, homelessness, neighborhood violence, and things like that. The thing that we do know is at least half of those schools are what are described within the education system as low-performing schools. Those make them of interest to those focused on education reform as much as they're of interest to child welfare and public systems who are working with those individual children. So it's both an individual child issue, but it's also a schools issue, and I think is a place that we can come together to work on that collaboration. In the evaluations that we've done, we've not dug into exactly what programs are put in place. I think it would be an area ripe for some work to see what sort of synergy there is for those programs. There probably are some initiatives and are programs in there. I don't know the extent to which they're trauma informed or they're aligned or they're collaborative with the public serving systems, but that'd be a good question.
Great. Gretchen,
Thanks.
introduce yourself.
I'm Gretchen Cusick with Chapin Hall. I'd like to get Jean's perspective, but then also I think either Cheryl or Margaret, it'd be nice to hear from the school's perspective as well. I'm curious about your take on the importance or not of age in terms of how youth experience trauma and the system's response to that trauma in terms of differences by age. Some of the things we see in the school, in the work that I've done in the schools in terms of system responses is perhaps that the responses to what may be trauma are likely to differ among the older youth and the younger youth. And are there particular things that, Jean, from your perspective, that systems should be paying attention to in terms of the age of the child? And then from the school's perspective, what are you seeing and what have the system's response are in terms of maybe some younger kids versus older kids, in terms of how should the systems really be responding?
Good question. As Cheryl said, systems are focusing largely on behaviors. So younger kids are easier to handle. Your 0 to 6-year-olds aren't acting out as much or as dangerous. And so I think then we tend to miss or minimize the impacts of trauma. Oh, well, they're young. The fact that there's domestic violence going on, they'll get over it. And so there, I think you're starting to see some of the early developmental deficits, the kids starting to fall behind, but you're not seeing the overt behavior, so it's a little harder to detect. By the time you get into late teenager, again, teenagers it's a high-risk period. If you look at back to the normal development, the kids are high risk all over the place, and if we could spend an hour doing war stories here of things we did as teenagers that we probably wouldn't do now as adults. And that gets exacerbated, and you get the kids really overreacting and going off. And that's where I say they really can be dangerous. And so I think it's the focus on behavior that makes you target the older kids and have those problems. What I really like are approaches like Bruce Perry's a wonderful trauma researcher, therapist, and he has, go to his website for Bruce Perry or Child Trauma Academy. Scholastic carries a lot of his educational articles. He has a whole theory of neurodevelopment where he will say, here's what normal development looks like, here's where trauma gets disruptive. And his treatment theory isn't just evidence-based practices, but it's a larger context, but it starts to note you have to start addressing the early developmental deficits because the later problems get built on top of it. So it's a sequential problem. It didn't start at 13. You're seeing it manifest itself differently then, but there's really some early developmental issues that have to be worked in. So I think the early stuff's more subtle, the later stuff is more overt, and we focus on the overt.
I think I would just add to that this isn't an issue just for the schools and the public systems. And it's an issue of foster parents as well. So, we did a study interviewing foster parents, and there were noticeable differences in the language that they used when they were talking about the real young children that they had in their home versus the older children. There was a tendency to use words more like defiant and oppositional and so forth with the older children, even though the behaviors might have been sort of similar. The other thing that I think is worth noting is that I feel like we can do a lot more in understanding how to fit some children with some evidence-based practices that are out there. So some of the practices are group-based, some are individual-based, and they may be evidence-based practices that you're putting in the schools. And I think you and Lisa have come across some of this in the Chicago Public Schools work that you've done as well. That you can make a certain intervention available. It may be a group-based intervention, but you may have some older kids that aren't quite ready for that group dynamic either. And so you really need to pay attention to the modality of what you're delivering as a trauma-informed practice and where the child is at and can fit with that.
I would just add that from what we've seen, trust and safety, little kids may be a little less reluctant to trust and to feel safe than the older kids who may have lived in crisis for many years. It doesn't mean it's not possible with persistence. It's very possible, but persistence is critical. Keep going back to that student. Keep trying to engage. I think that's important. And one thing that also stood out with me with the Fast Track program, meeting the kids, the younger children whose mom or grandmother is incarcerated, often they're depressed, they have nightmares, they're very upset, especially if they've seen their mother get arrested. And working with them in school, they're happy to see that social worker, etc. And with our older kids, they're embarrassed. They're really embarrassed that their mother's incarcerated. It's a whole different set. And of course, they're depressed too. They can become depressed through that. But they don't want to disclose because of the embarrassment attached. So there's some differences for sure.
Great. Let's go over to the other side of the room here.
Good morning, this is Krista Thomas, and I'm with the Children's Bureau here at the regional office in Chicago. And I was wondering what we know about a manifestation of trauma across different cultural groups, and I'm thinking specifically of maybe some immigrant and refugee populations who maybe have experienced layers of trauma, perhaps in the experiences that occurred in their communities of origin preempting the relocation, and then perhaps trauma experience with the acculturation process, or any challenges they may experience once they're here, like poverty. And if we have any interventions that have been designed specifically for immigrant and refugee populations that maybe weave in some protective factors that these families may be bringing along with them in addition to the traumatic experiences?
I would say the best group I'm aware of locally is Heartland, and they've had funding from the National Child Traumatic Stress Network to develop programs specifically to work with immigrants, refugee, and some political prisoner groups. And so I think they're probably best. I would say, are there comprehensive programs that are all tested, multiple places, evidence-based? No, not yet. I'd say, is it important? Absolutely. You know, I can give you one example I ran into that I didn't see coming at all. I had a teacher come to me and say that a girl in her classroom, her father had died, and the girl was now telling the teacher that she was seeing the father appear to her during the day in class, and it was kind of upsetting to her. And the teacher was thinking mental illness, this might be psychotic, hallucinating, whatever. I immediately started thinking trauma, you know, flashback, whatever, re-experience. Ends up the girl wasn't raised in this country originally, and you talk to the family, and in her family it was an honor to be visited by your ancestor. And so to the mother, that wasn't unusual at all. So huge cultural issues that come up that we all have to educate ourselves on, and don't over-pathologize and try and understand where they're coming from.
Margaret, can you speak to that from Rochester and the populations there?
We do have an international school, and the social workers work with youth and trauma in the international school. But to me, from my experience with my teenagers and the incarcerated kids and all these other vulnerable groups of kids, not to minimize anything that occurred in another country, but war zones are all over. So a lot of our kids live in war zones, and they can become traumatized as well as a result of living life in crisis.
Other questions? Let's go right here.
Hello, my name is Dina Gaucher, and I'm with DCFS. My question is more to Jean at this point. I'm concerned about a lot of times our children are so trauma affected that when they get involved with the mental health facilities, doctors, they get misdiagnosed. And so how do we begin the process of really informing our mental health providers, our doctors, not to, for the cliche, almost all of our kids are all bipolar now. You know, at one point they were all post-traumatic stress and things of that nature, but really utilizing the techniques of trauma-based practice so that our kids can get accurately treated for the things that they've occurred. They're not always at a mental health diagnosis where they always want to categorize our children, but more of that trauma-based and affected.
I think you've identified what I consider to be a huge problem right now, which is two well-meaning fields, if you will, mental health and child trauma, if you think of them as slightly different, are both trying to help the kids, but they're not coordinated right now. And two problems. First, you can look at the American Academy of Child and Adolescent Psychiatry. They put out a practice parameter on post-traumatic stress disorder, and there they go through 8 or 9 mental health diagnoses for kids listing the symptoms, and all those symptoms could also be explained by child trauma, meaning it's not really mental illness. And I've worked in mental health and I've worked in child welfare, and one of the things we said was stop calling all the kids in child welfare mentally ill. The problem right now is that our system, our healthcare system, is based on funding kids based on diagnosis. So Medicaid reimburses for diagnosis. Your insurance bases for reimburses based on diagnosis. So if you want to get the kids treatment, right now the only diagnosis, there is no child trauma diagnosis in the Diagnostic and Statistical Manual. There's only post-traumatic stress disorder, and as I explained, that's only touching 5 to 10%, whereas you got 50% needing treatment. And so the other 45%, if you want to get them treatment, you have to call them attention deficit, you have to call them bipolar, or you won't get treatment paid for. So it's a problem with the system. There's some movement now, the Diagnostic and Statistical Manual, the next version is supposed to come out in 2013. The American Psychiatric Association has its committees. There are trauma people who are who have proposed child trauma diagnoses to go in DSM-5. They're not all accepted yet. There's still research being done. That would help a lot. Part of it is also an education issue. I would argue start treating a kid as soon as you see a trauma symptom, and if you know that you've got a trauma history, you know you're seeing trauma symptoms, then work with that first before you start diagnosing mental illness like bipolar attention deficit. Because, you know, we talk about best practices. Best practices for mental illness are different. Bipolar and attention deficit, you start medicating. Those are best practices. Trauma, you don't. You got a kid with a classic example, attention deficit, you give Ritalin, which is a stimulant. If it's really trauma that the kid's hyperaroused because of, the last thing that kid needs is a stimulant. And so both are well-meaning, but you really got to do some differential diagnosis, and right now our healthcare system doesn't support that.
Great. Here in front, if you could wait a second for the microphone. Thanks.
Thank you. My name, is it on?
Yeah.
My name is Jacob Dancer. I'm from UCAN, it's a child welfare agency in Chicago. So you guys were speaking about child welfare professionals have expertise in assessing, and educational professionals have expertise in instruction. One of the things that I've been experiencing is the daunting task of training all of these people to get them into one accord as to what Gene's talking about, having a clear understanding of what healthy development is. So everybody has an operationally defined understanding of it. That'd be great. If everybody understands what trauma is, that'd be great. My question to you guys is, and starting with Gene on the way down, is how do we come up with having some kind of policy in place where this training is actually happening, instead of just have it, we all in the room talking about what needs to happen, but there isn't any kind of funding to have the manpower to do this type of training. There isn't one walking to the school and actually saying, okay, everyone needs to sit down and listen to Gene, Cheryl, or Margaret talk about these perspectives, or even anybody else in this room, because there's nothing happening as far as a funding perspective. So if anyone has any comments on that, I would love to hear that.
Gene passes.
It's a great question. I think we should at least recognize there are some efforts going on, right? The Illinois Department of Children and Family Services has decided to take upon it itself to, really push that training out there. And I think in recognition of that, there are more opportunities through various grants for some training. I'll leave it to Gene to talk about the networks and so forth also. But I would say what I'd really like to see, though, is that those trainings are co-occurring, right? I think the dialogue across the systems can be very valuable. So you can train for trauma-informed perspectives within child welfare, and you can train for trauma-informed perspectives within education, and you might still have some work to do to bring those people to the table to talk about the same issues or the same children that they're working with. And I think there's great value in doing that across the systems.
I do think there's some optimism here in terms of even nationally. The National Child Traumatic Stress Network funds centers. Right now there are 7 sites in Illinois that have National Child Traumatic Stress Network funding, and so they're trying to develop and spread programs. Even better example, Brian Samuels is the current Commissioner, Health and Human Services Administration for Children, Youth, and Families that does all the child welfare funding federally. He was director here in Illinois when we started the child trauma program in child welfare. They just put out a multi-year grant to make child welfare systems trauma informed. They just revised, just got approved, the child welfare legislation got reenacted, and they inserted trauma in there. Before it said child welfare has to assess for mental health and treat it. Now it says mental health and trauma. That just came out, that has huge potential to bring out some standard training and treatment programs. So are you going to see that real soon? No, but are there pieces there that it's starting to spread? Yeah, I think so. It's always hardest on the ground. It's easy for me to sit here and talk. It's much harder to help you when you're working with the people that are actually seeing the kids directly. Matt, you're involved a lot more national stuff. Can I pull you in here?
No, I think that this funding opportunity, the opportunity presented by the legislation noting this is something Gene and I were talking about before the session today. It is, you can look at it and say that's just a word in a legislation piece that nobody ever reads. But you also, knowing that the Children's Bureau is going to help states reframe this, knowing that state and county agencies will be moving in this direction. It really could be a large change to redirect some funding toward this type of activity, as well as increasing the conversation about it. I think the conversation is clearly increased. Brian's work is behind a lot of that, but we have to get beyond the conversation toward real embedded pieces in each of these systems. And I'd echo what Cheryl says about the need to bring the systems together at the front line level as well as at the agency manager level. Margaret, did you want to reflect on this?
The only thing I would say is we're kind of lucky in this because not only is our superintendent committed, as this is a goal for trauma-informed staff, but our county partners are very ingrained into the trauma-informed work and have offered to train a group from the city school district so that we could turnkey and we're on the same page. That's part of our collaborative, like coming together and having those point people that we can work with and filter it down through our systems. We're in a much smaller situation, certainly, but part of the importance of the collaborative is also the professional development.
Margaret, I'm going to take the last question here and ask you, since we are pleased to have stolen your former superintendent of schools, can you say a word about his involvement in building the system and what those of us in Chicago might do with new leadership at the Chicago Public Schools to help enhance attention to this issue and build the kind of system that you've seen in Rochester?
Well, Mr. Brizard is very interested in graduating students and graduating youth. And I know he knows the value of the non-academic portion also. We've talked about it. And he's been supportive in Rochester of moving our vulnerable youth through the system so that they can graduate with their group. He's been very supportive of that.
Great. I'm afraid we are out of time, but I hope on this topic especially that we haven't just talked ourselves for an hour and a half, but we've generated a part of an ongoing conversation on this issue that will resonate again at the practice level as well as at the policy level, and especially across the systems that these youth touch. So I want to thank everyone who joined us long distance via the web, as well as those of you who took time out of your busy schedules to come join us in person. And I want to ask you in turn to thank our panel for their presentations today.